All right. Good morning, everyone. Thank you to for joining us for our September 8th clinical conference. We'll give it one more minute or so as people join in, and then I'll introduce our speaker. All right, good morning, everyone. Thank you for joining us this beautiful, almost fall morning, at least here in Seattle, for our September AIDS clinical conference. I am very excited to introduce our speaker and my colleague, Dr. Jehan Budak, who is an assistant professor here at the University of Washington in the Division of Infectious Diseases and is also the assistant director of the Madison Clinic here in Seattle, and among many other hats that she wears. She also runs the MOD Clinic, which is a low barrier walk-in clinic within Madison Clinic. And she also works with David Spock doing national HIV curriculum and is the head of our HIV Pathway for trainees in internal medicine wishing to do HIV primary care. So this is a very appropriate topic for her to present. So thank you so much.
Thank you, Shreesha. Well, good morning, everybody. As Shreesha mentioned, we'll be talking about HIV primary care. Just advancing my slides here. I have no conflicts of interest or relationships to disclose. However, I will acknowledge Dr. Todd Brown, who is an endocrinologist who specializes in HIV at Hopkins, for guidance on osteoporosis. And I'll talk a little bit more about Dr. Brown shortly. And the data presented in this presentation offers a limited glimpse of health inequities that exist within a larger social context, and it's racism, not race, that creates and perpetuates health disparities. So I wanted to start off just by sharing that these guidelines exist. This is the HIVMA primary care guidance that came out in 2020, was published in the in Clinical Infectious Diseases, and is about 35 pages of text with many references that is really kind of our go-to for primary care guidance regarding about HIV primary care. When thinking about what to talk about for today, I didn't want to go through the entire guidelines. I don't think that that would do it much justice. And so instead have decided to just focus on three aspects of things we might see in primary care for persons with HIV. So by the end of today, my hope is that you will be able to describe an approach to osteoporosis screening and treatment in people with HIV, to define low-level viremia and describe options for its management. Although low-level viremia is not in the HIV primary care guidelines, it is something that we see a lot of in clinic, and it is uncomfortable. And so I thought I would spend some time talking about that. And then last, discussing the relationship between ART, or antiretroviral therapy, and weight gain. And so we'll spend most of our time on objectives 1 and 3. And so let's get started. So first, with osteoporosis, I'd like to first ask, at what age should screening for osteoporosis in a cisgender man with HIV begin? Is it 45, 50, 55, or 60? I think that is good. And it appears we've got a bit of a spread. 60% of you said at age 50, which is the correct answer. And let's talk a little bit about why we do this. And to do so, I'd like to share a case of a patient of mine who's a 50-year-old man with well-controlled HIV who was switched from Bictaf FTC to TDF3TC doravirine or Delstrigo after experiencing weight gain. And approximately 1 year later, we finally finished up all of our other healthcare maintenance and decided to get a Dexa scan. His Dexa results showed a T-score of -2.6 at the L spine, -2.5 at the hip, and then -2.7 at the femoral neck. At that point, I did a bit of a workup for secondary causes for osteoporosis and showed he had a vitamin D level of 23 and a normal free testosterone. So this is kind of the case that I wanted to discuss, or at least jump off of and go into talking a little bit more about osteoporosis. So a bit about background about osteoporosis in general. I think we see it a lot, but none of us really feel expert in this. And so osteoporosis is, one definition is that it is a systemic skeletal disorder characterized by low bone mass and microarchitectural deterioration of bone tissue or bone quality, with a consequent increase in bone fragility and fractures. And it is mostly diagnosed based on DEXA, or dual energy X-ray absorptiometry, which is a difficult word to say. A normal DEXA score is a T-score less than or greater than -1.0. Osteopenia is then a T-score of -1.0 to -2.4. And then osteoporosis is a T-score of less than -2.5. Now, there's a couple of things here about this. A Dexa scan or score will only tell us about the bone mineral density and doesn't tell us about the bone quality. And this, a Dexa or bone mineral density really only gives us about like 50% of the fracture risk, because again, we're missing bone quality in that number. And then we're also missing these other structural factors that can contribute to fractures, including falls, for example. The other thing that I haven't included on here is the concept of osteomalacia, which is actually where the bone structure is fine, but the bones are actually, in my mind, I think of as soggy or having issues with mineralization. And that is different than what a Dexa scan will show. And a Dexa won't necessarily tell you that. And the issue is that you really want to think about that, because oftentimes bisphosphonates won't help that. Not oftentimes, bisphosphonates just won't help that. And sometimes theoretically, bisphosphonates can actually hamper remineralization. So that's something to consider. So big picture, osteoporosis, diagnosed by a Dexa scan, and that is based on a T-score of less than -2.5. Now, I think a lot of us have heard about Z-scores. And what is that? That's just another score that's actually used in men less than the age of 50, and then also in premenopausal women. And an abnormal Z-score is if it is less than -2.0. I think it's kind of rare that we'll be getting a Dexa scan in someone who is less than 50 or premenopausal, though we'll talk about situations in which that might be the case. And so if that's the case, again, look for that score of less than -2.0. Notice that I didn't say it's osteoporosis if it's less than -2.0. Technically with the Z-score, it's just, will tell you, you can just say that it's abnormal. If there is a fracture, then that constitutes osteoporosis. There's something about needing to have a T-score to really sort of get that specific diagnosis based on a Dexa scan alone. And then the other thing I just wanted to show here, for those of you who may not be very familiar with it, is that this is kind of what a Dexa scan looks like. It's very easy in case you have any patients that have apprehension about this. It takes about 20 minutes and you kind of lay down. They take pictures of your hip, both at the hip and the femoral neck, and then also of the lumbar spine. Now, let's say you have a patient who has instrumentation at either the hip or the L spine, then they can use actually the distal third of the forearm to figure out the bone mineral density instead. So again, very easy. A patient does, this is sort of misrepresented because usually the patient is in a gown, but this is a very easy thing to happen. Now, a little bit about the relationship between HIV and osteoporosis. So osteoporosis is more common in people with HIV compared to age-matched individuals without HIV. And people with HIV have a higher risk of low bone mineral density, or BMD, and fragility fractures. The reasons for this are multifactorial, but a couple that I just want to share is that, ART, as we're aware of, contributes specifically tenofovir disoproxil fumarate and the protease inhibitors. But it's not just these two that are culprits. That ART initiation on its own can lead to a 2 to 6% loss in bone mineral density during the first 2 years of therapy. When I was preparing this talk, I found some data that showed that even use of abacavir and 3-TC, for example, can lead to some decrease in bone mineral density. A little bit more at the sort of microscopic level, I think this is really interesting that HIV itself can infect osteoclast precursors, because typically with bones, there's osteoblasts building up the bone and osteoclasts breaking down the bone. And HIV actually infects osteoclast precursors, can kind of turn them on or rev them up and increase bone resorption. So that, I thought, is yet another mechanism in which osteoporosis we see more of in people with HIV. And then in addition, some other factors, there's increased risk of osteoporosis with hepatitis C, which we also commonly see in people with HIV. This is an image that I have drawn from one of Dr. Brown's talks, just highlighting that the etiologies of bone loss in HIV are multifactorial. I will highlight some of these things where there are some contributions, or can be, between hypogonadism, smoking, alcohol, hep C, as we talked about, or some other things that we may see in HIV. Again, with ART, we've seen the direct effect on bone cells, inadequate mineralization and immune reconstitution, and then the virus itself with a direct effect of viral proteins on bone cells, as I've just shared, and immune activation. And then I wanted to highlight that there are these guidelines, the recommendations for evaluation and management of bone disease in HIV. This came out in 2015, also housed in CID, or clinical infectious diseases, and are really helpful guidelines for managing bone disease in persons with HIV. So again, I'd like to just acknowledge Dr. Brown, whose talk I have been to before, which was very helpful in creating this, but also who took time to speak with me to make sure that all of us can be as expert in this as possible. And so drawing from those guidelines is this image that really sort of gives you a flow sheet on what to do. And we're going to break this down. And just to highlight, it starts off with screening, assessment, management, and monitoring. So as I mentioned, one of our objectives is to describe an approach to osteoporosis. So first off, screening for osteoporosis in persons with HIV. First, if you have no risk factors and you're younger than 40 years, then no screening is necessary. If you have no risk factors and you're 40 to 50 years, you can calculate a fracture risk by using the FRAX score, which we'll talk about shortly. If you are an adult with a history of fragility fracture, glucocorticoid use, here they use greater than 5 milligrams for 3 months, and a high risk at falls at any age to proceed with bone mineral density testing via Dexa. And then now, because there's so many different arrows here, if you have no risk factors, if you're an adult with HIV without risk factors, and you are a postmenopausal woman or a man greater than 50 years, then you do need to evaluate for this. This guideline was actually an international guideline bringing together people from multiple different countries. And here it states that you should do a FRAX if Dexa is not readily available. In the UK, as opposed to the US, Dexa scans are not as readily available. And so there they will actually calculate a FRAX score prior to getting a Dexa scan, whereas here in the US, the recommendation is to go straight for a Dexa scan. So what is the FRAX score that I'm mentioning? It's a clinical fracture risk assessment tool, and it kind of gives you a little bit more information than just the Dexa scan alone. You'll see here that it is only validated for ages 40 to 90, so you'll put in some information here, the sex of the patient, weight, height, and then if they've had a previous fracture, if their parent has ever had a fractured hip, you also want to just ask about family history of osteoporosis, as it is quite important in sort of deciding if osteoporosis will be seen in your patient. If they're currently smoking, if they're on steroids, if they have a history of RA, if they have secondary osteoporosis, or if they drink alcohol, and here they say three or more units per day. Now, again, you can calculate a FRAX with a bone mineral density here or without. And as mentioned, in the UK, they will do this without, and then use that score to help determine if they should get a BM or a Dexa scan. And then here, we do use it with a Dexa scan, so just input that information there. So when should you use the FRAX here in our practice? Use the FRAX if the patient's less than 50, but actually has to be greater than 40. If you do not have access to a Dexa scan, or if you receive a Dexa result with osteopenia, because then, and we'll talk about this shortly, if you have a result with osteopenia, the FRAX score can help determine if you should just, do general measures, calcium, vitamin D, and continue to monitor with a yearly Dexa scan, or if you should actually proceed with bisphosphonate therapy if someone's fracture risk is high enough. Again, the Dexa result is just showing the bone mineral density and kind of the structure, but is not telling us anything else about the quality of the bones, and the FRAX can help with that. Now, the FRAX is not a perfect measure. And in fact, we have data that the FRAX underestimates risk of osteoporosis in people with HIV, just like the Framingham risk calculator does. Now, there are some people, and it's actually, I believe it is this paper that suggested that you should click on secondary osteoporosis as kind of a marker of HIV if this person has HIV. Now, if you do not have a Dexa scan, then that makes sense. So if you're just calculating a FRAX score, go ahead and click yes for secondary osteoporosis, as HIV is a risk factor. However, if you have a bone mineral density score, clicking that won't change your score. And so as a result, I think for the vast majority of us who will be using the FRAX score only if we get a Dexa result with osteopenia, since we have such ready access to Dexa scans. If you are using it in that regard, and then, I mean, you don't really need to click that button. So again, for the vast majority of us in the US, we do not need to change this to say yes. But if for some reason you are calculating with a FRAX score alone without a Dexa scan, then sure, go ahead and click that button. And here is that, just what I said. So once you've gotten the FRAX score, again, let's sort of see what we're supposed to do. So here, if you're, again, younger than 40 years, you don't need to screen. And if you're 40 to 50 years, it says to calculate a FRAX score. If it's less than 10%, manage with calcium, vitamin D, and lifestyle advice. Whereas then here, if we've measured the bone mineral density, and here the T-score shows osteopenia, yet the FRAX score is less than 20%, then again, just continue with general measures and continue to monitor. Here's the kind of key part where it's like, when do you actually decide to treat? Well, I have another slide that talks about that, but it will tell you that intervention threshold is determined by country-specific guidelines. And in the US, we use a T-score of less than -2.5 at the femoral neck, at the hip, or the lumbar spine. So any of those places, if there's a -2.5 or higher, then or lower, then treat. Or if you have a T-score between -1.0 and -2.5, i.e. osteopenia, and your FRAX score is greater than 20% or greater than 3%, or if you have a hip or vertebral fracture, then you should exclude secondary causes of osteoporosis and consider bisphosphonate therapy. So I've already mentioned some of these general management for bone health comments, and I'd like to just highlight that we should, for these patients, ensure adequate calcium on calcium intake. And here it says, Chase has asked, is a FRAX tool free to use somewhere online? I used it yesterday and it was free. And so if you just use this, let's see, the link here, it should be accessible. So adequate calcium intake. I think the vast majority of people should get calcium from their meals. And this is also what Dr. Brown suggests. And that if you have a person who doesn't actually take much calcium, then you need to supplement with a pill. So I do not drink much milk. And so I should be taking perhaps calcium about 1,000 per day. However, if other people have a diet rich in calcium, then no need to supplement. It is important to ensure vitamin D repletion, about 1,000 IUs daily, probably for all of us. And then lifestyle modifications that can be better and helpful for bone health include smoking cessation, alcohol reduction, and weight-bearing exercise. And interestingly, cycling or swimming does not count as weight-bearing exercise, which actually makes sense, but it's really sort of walking is better. And then obviously lifting weights and such can be most helpful. And then it's also important to evaluate for secondary causes of osteoporosis prior to starting treatment. So if I have a patient with osteopenia, I am not evaluating for secondary causes of that. But if I have diagnosed somebody with osteoporosis, then as you saw in the case, this patient of mine in clinic, I did evaluate for secondary causes of osteoporosis. And so for that, I have now learned that the full complement of those labs should be a calcium, a vitamin D, a PTH, a free T in a cisgender man, and maybe a TSH, really depending on the patient's sort of symptoms. And then other rarer causes such as Cushing's, multiple myeloma, et cetera, can be worked up based on a review of systems that you've taken from the patient. And in these scenarios, if you do find an underlying cause or a secondary cause of osteoporosis, the recommendation is to address that underlying issue and then repeat a Dexa scan in 6 months. Now, this is not to say that you have to follow this. I think what I've really learned is that osteoporosis management is really kind of can be subjective at times, especially because the Dexa scan is not perfect. And so if you have someone who has fractures or is falling a lot, and you find that they have vitamin D deficiency, you do not have to wait to fix that before starting the bisphosphonate. So really, it's okay to use your clinical judgment in these scenarios. However, for the vast majority of people, it is recommended to address the underlying cause and then repeat a Dexa scan in 6 months. And then at that point, decide if you want to use the bisphosphonate or not. Now, in my case with the patient, unfortunately, he just didn't want to start a bisphosphonate. And so we are really trying with calcium and vitamin D and going to repeat a Dexa scan with some shared decision making. We were able to say that we would try that first, see what happens, and go from there. So that's my patient. Then, if you've got a patient with osteoporosis or even penia, it's important to optimize ART if possible. So again, we should be avoiding PIs, which most of us aren't using, and TDF if possible. You'll notice that this patient I had actually put on TDF, 3TC, and doravirine because he had experienced such weight gain, which we'll be talking about shortly. And so, was it the TDF or was it something else? I'm not sure. However, we did promptly take him off of the TDF. Now, switching from TDF to TAF does indeed lead to improvements in bone mineral density. There's one study that showed that over 48 weeks, by that switching from TDF to TAF can improve bone mineral density by plus 1.5 to 2.3 the score in a Dexa scan, which is very high. But then some more recent data that was actually not that recent was shared at CROI in 2017 showed that in a switch from a TDF containing regimen to TAF FTC Kobe alpha-tegravir at 96 weeks showed a bone mineral density increase by approximately 2.5%. And in general, a reversion from osteoporosis occurred in approximately a quarter of patients. So takeaway from this is switching from TDF to TAF in about a quarter of patients can change someone from having osteoporosis to osteopenia. And then if you have a patient with osteoporosis, it is okay to use TAF. I again verified this with Dr. Brown, who had said this several years ago and continues to say this. TAF is bone neutral. However, now you can also switch to a tenofovir sparing regimen entirely. We have many regimens that spare that, and it is okay to use that. Unfortunately, we do not have head-to-head data of what is better for the bone, switching someone to TAF or switching someone to a completely tenofovir or TAF sparing regimen. We don't know. I don't think that we'll ever get that data. There will be no RCT about that. So I think, again, okay to use or do either one. And then how to treat osteoporosis. Now, we're not going to focus on all the medications that we can treat osteoporosis with, but we will talk about the bisphosphonates, which I think is in our wheelhouse a little bit more, especially alendronate. So of the anti-resorptives, so sort of blocking breakdown of bones, or at least trying to help with that, are the bisphosphonates. Alendronate or zoledronic acid are the most commonly used ones. There are some other oral bisphosphonates, so in addition to alendronate, such as I can't even say them. It's like resendronate or brevinate. And then zoledronic acid is a once yearly infusion. There's denosumab, which is a monoclonal antibody. Some of the raloxifene or the selective estrogen receptor modulator, and then estrogen itself. And then there are the anabolic parts that actually help with bone building up. And those are the PTH or PTHRP analogs, such as teriparatide or abaloparatide, and then a sclerostin inhibitor, which I have never used. And so again, I think to highlight that we, again, in our wheelhouse should be oral bisphosphonates. I do anticipate using zoledronic acid more and more, and I'll talk about that. However, I will need some guidance from endocrinology at that point. And if I'm thinking about any of these other medications, then I will definitely need the guidance of an endocrinologist. So now that we've talked a little bit about what the treatment options are, again, as a reminder, who to treat. We talked about this a few slides ago, but those with a hip or vertebral fracture, those with osteoporosis with a bone mineral density score of less than negative 2.5, or those with osteopenia with a FRAX score greater than 20%, or the hip fracture score greater than 3% on FRAX. And I did not show this, but the FRAX will give you both that sort of general osteoporosis risk and then risk of hip fracture. And then, and as I mentioned, in HIV primary care, use bisphosphonates. For other agents, consult endocrine. Alendronate, as mentioned, is a weekly oral pill. Issues with alendronate, in addition to the fact that you can't lay down for 30 minutes after taking it, which is surmountable, is that they have poor bioavailability. In fact, alendronate, for example, has really only 10% oral bioavailability. And so it's not great. And adherence is difficult. There is issues with bisphosphonate persistence. People stop taking the medication. In fact, while I was on vacation visiting my parents, I just found out that my mother stopped taking her alendronate for fun. And so I think that is emblematic of the fact that it is difficult to continue to take a medication, and there is a pretty big drop-off when it comes to bisphosphonates. Also an issue because even when you take it, the bioavailability is low. So zoledronic acid, there's a fair amount of data in people with HIV using zoledronic acid, and it sounds like at least the endocrinologists are using this more and more. It is a once yearly infusion, essentially DOT, and the sort of downside of that is that about 25 to 30% of people can actually experience flu-like symptoms for the first 1 to 2 days after the infusion. So that is something to highlight and mention to the patient. So especially in the time of COVID, it's important to recognize that that might be an issue. And this can be arranged through a infusion center. So monitoring here, if you have, again, no issues to monitor fracs in 2 to 3 years. I see that Hillary mentioned more a comment, but with calcium use, remember to consider drug interactions. Totally, we have so many ART, or mostly the INSTIs that we can't really, that we need to be mindful of when using with calcium. And then great question about how often to repeat the Dexa if normal. And if on treatment, we'll talk about that shortly. I don't really have a slide on how often to repeat the Dexa if normal, but here they're recommending to get a frax every 2 to 3 years. And I would be doing that, I think, as well with a Dexa scan. This, again, is something that is an area that I think I would love a little more guidance on, but I think every couple of years for a Dexa scan is totally appropriate. However, I think also using that frax score can be helpful in those scenarios, maybe even yearly if you are not getting that Dexa scan. So other monitoring is, let's say here, again, it's just imagine this is the osteopenia, to repeat the Dexa scan in 1 to 2 years if there's advanced osteopenia, 5 years of mild to moderate. I've also seen seen other individuals recommend getting a Dexa every year if there's osteopenia. So if there's a normal Dexa scan every couple of years, osteopenia every, again, some clinicians recommend every year. And then for a Dexa scan, then that is, if you're being treated, then the recommendation is several years. And we'll talk about that on the next slide. So osteopenia, repeat Dexa yearly. That's what I'm going to be doing. For osteoporosis, treat for 3 years with zoledronic acid or 5 years with alendronate before repeating a Dexa scan or even thinking about it. And then at that point, obtain a Dexa scan to evaluate for possibility of a drug holiday. One, again, it's nice to not take a medication, but the bisphosphonates do have the risk of osteonecrosis of the jaw or atypical femoral fractures. And so it'll be nice to sort of minimize that risk. Use that Dexa scan to, again, help you evaluate if you should have a drug holiday from the bisphosphonates. And if you do meet criteria for a drug holiday to stop the medication, continue with calcium and vitamin D and check a Dexa yearly. There's this table from one paper that's helpful that is recommended to be used for what to do regarding a drug holiday. And so when you have come to that 3 years with zoledronic acid or 5 years with alendronate, take a peek at this. And if they're high risk, where the T-score is still less than -2.5, drug holiday is not justified, or previous fracture of the hip or spine, or ongoing high-dose glucocorticoid therapy, this person does not meet criteria to stop the bisphosphonate. However, for these other sort of individuals who are maybe moderate risk or low risk, then you can consider a drug holiday. So this is a table I recommend using after you have treated your patient for 3 to 5 years and you're considering a drug holiday, which will be informed by your Dexa scan, but also the clinical picture of the patient. Again, remembering the Dexa is not really telling us much about the bone quality, and it's sort of missing those other factors such as falls, etc. And so To finish up with osteoporosis, some key points is that there's a higher risk of osteoporosis in people with HIV beyond just risk from ART, mostly TDF. To screen for osteoporosis with Dexa in people with HIV who are with men greater than 50 or cisgender men greater than 50 and postmenopausal women. That if a Dexa scan shows osteopenia, calculate a FRAX score and recognize that the FRAX can underestimate risk in people with HIV. If Dexa shows osteoporosis, treat with a bisphosphonate for 3 to 5 years. TAF can be used in persons with osteoporosis, and we need more data in PrEP use and osteoporosis. I don't have a section on this. I know we're talking mostly about HIV primary care, but I really wonder about the risk of sort of TDF use in PrEP. We don't have much data about this. Hopefully there were some analyses from HP2N 083, and so hopefully we'll get some results of those probably maybe at CROI, where, probably not surprisingly, cabotegravir does not have effects on bone, whereas TDF does. Recall that oftentimes PrEP use is cyclical, so people are on it for a short amount of time, and these are younger people. Now, that is something to know that in adolescence, there was some studies that showed that PrEP use might sort of prohibit someone from reaching their peak bone mineral density, which tends to happen around the age of 25 to 30. So maybe if someone who is developing their bones, cabotegravir may be a better option. I think we don't know. This is still an area that we need more information. I've asked if we'll get more information. Will there be really good studies? I think it's going to be tough. This is hard data to get because oftentimes when it comes to osteoporosis, you really want to study or sort of watch someone for a long amount of time. And I think we'll get more information, but I think it will continue to be nebulous. If you have someone who's on PrEP and is older, with at least on PrEP with Truvada, then I think, perhaps you may want to calculate a FRAX score or have a low threshold to get a Dexa scan. I think really my sort of takeaways from this is that you don't have to be so strict with management of osteoporosis, that there is a little bit of that sort of clinical judgment, especially if someone's had a family history of osteoporosis, where you can have a lower threshold to get a Dexa scan and consider screening. And then Hillary said, is there any data about decrease in fracture risk in people with HIV and bisphosphonates? Not that I found. There is data about use of zoledronic acid improving bone mineral density. I don't remember about the decreased fracture, if they looked at decreased fracture risk. So that, I'm sorry, Hillary, I don't know the answer to. Okay, moving on to low-level viremia. A 60-year-old man with HIV whose last CD4 count was 478 and viral load was 80 and multiple medical problems is seen for routine follow-up. He has been taking, this is a patient of mine, TAF FTC, dolutegravir, moravirok, and boosted darunavir BID since 2016. And he is someone that I met in 2019 when I took over, or in 2020 when I actually took over his care for someone. His most recent genotype, which was many years ago, showed an M184V, an M41L, and a T215Y, so 2 TAMs and an M184V, and an RTI mutations here with a K103N, a Y181C, and an H221Y, and 1 PI mutation, but no integrase resistance. And a little key for people about what these resistances mean is that, with the M184V, we have resistance to abacavir 3TC and FTC. With the 2 TAMs, we have resistance to abacavir and tenofovir. Building up that with the K103N, we have resistance to efavirenz and nevirapine. So Y181C, we have resistance to almost all NNRTIs. And then with the I84V, there's low-level resistance to darunavir. So this is a patient that I inherited. I thought, whoa, you're on a lot of medications. I'm actually not sure you need all of these. I feel uncomfortable with the fact that your viral load is 80. And so I was hesitant to simplify his regimen, especially since it wasn't suppressing him. And this was a sort of graph of his viral loads. So as you can see, in 2016, we had something here that was in the sort of 50 range, and then kind of bouncing around at its peak, reaching 120, but otherwise just hanging around here. And so I did do a bit of an adherence review of systems with him, asking about missed doses. I asked, when was the last time you missed a dose? To which he said, can't remember. And in the past week or month, how many doses did you miss? He said, none. And I always ask those 2 questions of everyone. I asked him about logistics of taking the medications. I was asking, what is your system for taking your pills? How do you take your ART? Do you take it with food? Do you take all your pills together? And he takes all of his pills together, takes it with food, and again, is very fastidious, has very nice spreadsheets of this and about taking his meds, and denied having he has a stockpile of a couple of medications, but doesn't have a stockpile of tons of medications, indicating perhaps non-adherence. And then as far as drug-drug interactions, I've reviewed his medication list and then asked him, beyond your medication list, what over-the-counter meds do you take? Do you take any vitamins or supplements? To which he said, anything, he only takes what we prescribe. And then last, I also asked some more existential questions. How do you feel about your ART? What issues or annoyances do you have with your ART? And he's very pragmatic. I think he told me that he was frustrated. He has so many pills that he has to take, but he also has polypharmacy from his other multiple medical problems. But otherwise, again, very pragmatic. He's like, this is what I need to keep living. I take my meds all the time. And he was just, again, very pragmatic about this. I did wonder sort of about the concept of white coat adherence. Could he be taking his medications like in a short amount of time leading up to coming in? That is sometimes something I do think about with patients, but with him, that is not the impression that I got. And again, asked him a couple more questions about adherence, and I trusted that he was taking his medications as prescribed. So with that review system, with that sort of adherence history, what would you do with his ART in the setting of his low-level viremia? Would you continue his current regimen? Would you add fostemsavir? Would you double the dolutegravir dose, or would you add doravirine? Seems like and I think we can close the poll. Thank you. And it seems like the vast majority of people would opt to continue the current regimen. Some people wanted to double the dolutegravir dose, and some people wanted to add fostemsavir. Again, what I did was that I continued his current regimen. We'll talk about that. I also considered whether or not I should get a darunavir level in him. But again, I felt that that would be treating myself and not so much the patient, because we wanted to be mindful of cost, and also because, again, I did trust in his adherence history. We'll talk about some of the other options, and notably, since he does not have integrase resistance, we did not double the dolutegravir dose, and we'll talk about how we do not need to do that even in the presence of low-level viremia. So I thought that it would be helpful to talk about some definitions first regarding virologic response, and those definitions would be incomplete virologic response, virologic blip, virologic rebound, and low-level viremia. So for incomplete virologic response, that is the failure to suppress HIV RNA to undetectable after 24 weeks of an ARB regimen. Whereas a virologic blip is after you've achieved virologic suppression, having a single undetectable HIV RNA level, usually less than 200, followed by a return to suppression. I would say the vast majority of the viral loads that I see that are, between 40 to 200 are this virologic blip where something goes up and then it just comes right back down. Virologic rebound is having confirmed viral load and sustained greater than 200 after having achieved virologic suppression on ART. So virologic rebound where it's coming back and oftentimes progressing to failure. And then low-level viremia, which is what we're talking about, is a persistent HIV RNA level above the level of detection for the assay, but often less than 200. So usually in the 50 to 199 range. So possible etiologies include suboptimal adherence, drug interactions, drug-food interactions, early virologic failure, or none of the above. This is rare. We don't see it that often. It is very anxiety-inducing for both patients and providers alike, but it is rare. And we have some pretty recent incidence data of a cohort of about 1,500 people from Taiwan who actually switched to dolutegravir, bictegravir, second-generation integrase inhibitors, which are super potent and have high barriers to resistance. So good medications between a 5-year period, and the incidence of low-level viremia, again, even on these great medications, range from 1.2 to 1.7%. And really, I think most people feel that persistent low-level viremia in the setting of excellent adherence to a potent ARV regimen is felt to be due to replication incompetent HIV being released from a latent reservoir. So I think that is the sort of what most people believe low-level viremia to be. And the data on low-level viremia is mostly conflicting. You can, in sort of every year I've looked at, and this is not a comprehensive review, but some people say that it is fine, and some papers say it is not fine. So one, study showed that low-level viremia was associated with increased mortality, and then yet another paper shows that it is not. And then most studies have shown a low risk of virologic resistance in persons with persistently detectable viral load less than 200. But then in another group that it was associated with virologic failure, whereas most recently in this Taiwanese cohort, there was no increased risk of virologic failure. I think when it comes to sort of the mortality, jury's out. I think we don't really know. Again, some papers say yes, some papers say no. However, I feel pretty comfortable saying that although there is still conflicting data regarding the risk of virologic resistance, the vast majority of them say that there is a low risk of that. And then adding drugs does not work. There's this one paper by Raj Gandhi who actually added raltegravir to a already sort of good regimen based on the resistance profile, and adding raltegravir didn't work. So adding more drugs, doubling doses that don't need to be doubled unless there's resistance suggesting that won't help. So more is not better in this regard. And what do the guidelines say? So the DHHS states that adult and adolescent that they recommend persons with low-level viremia continue the same antiretroviral regimen, but undergo monitoring with HIV RNA levels every 3 months. So again, I think about 60% of people picked this option. And then the IAS USA guidelines states that patients with intermittent or persistent low-level viremia between 50 to 200 should be assessed for treatment adherence, tolerability, and toxicity. However, changing ART regimens is not recommended unless ART toxicity or intolerability are identified. And I think as a reminder, I wanted to comment that undetectable equals untransmittable, or U equals U. The concept that an individual with an undetectable HIV viral load cannot transmit HIV to their sexual partners. These are the 3 studies that really sort of helped sort of prove U equals U, HP2N052, partner 1 and partner 2, of which I do frequently discuss partner 2 with patients, where in 970 serodiscordant and MSM who were coupled that had 76,000 condomless sex acts, no HIV infections were phylogenetically linked. And the reason why I'm showing this slide is that because in all of these studies, the viral load that they used as undetectable, or the sort of cutoff, was a viral load less than 200. So in patients with low-level viremia, U still equals U. And you saw with this patient that his sort of viral load got as high as 120, but it's not. And please sort of comment in the Q&A if you have seen this, but when I've had patients with low-level viremia, sort of they'll like bop around less than that 200, but I haven't seen people, go all the way up to like 400 and then come back down. And so from that regard, again, although low-level viremia is very concerning, it should not lead to HIV being transmitted. And so some key points is that low-level viremia is defined as persistent HIV RNA levels above the level of detection for the assay, but below 200. To assess adherence, ask exactly how the patient takes medications and assess drug interactions, food requirements, and absorption. That low-level viremia, based on the literature, may or may not increase risk of virologic failure and or mortality. I think I don't really believe this one, but this I'm not sure about. So again, I'm pointing here to virologic failure. I don't really think that's happening. Whereas with mortality, I think we don't really know. Again, the data is super conflicting on this. And then if the patient's on an ART regimen with a low barrier to resistance, please do update the ART. Otherwise, changing or intensifying ART is not recommended. And as Dr. Paul Sachs has written in his blog, regardless, the absolute risk of failure is still quite low, especially if adherence is good, and patients do not appear to be slowly developing resistance to the regimens. To sort of close up the story of this case, I ended up, as I mentioned, I continued this current regimen. Subsequently, the patient developed cardiac disease, and I decided that we did not need the darunavir We made some other changes, so he's off darunavir, and I believe is now on fostemsavir. And at some point, his viral load became undetectable. And I remember sitting with him here in the Madison Clinic, being very excited about it. And I was like, what do you think's different? Like, hoping that maybe he'll tell me something that I had missed. And he was like, I did the same thing. And he was like, you know, sometimes with your viral load, sometimes it's elevated, sometimes it's not. You just do what you can do. And I was like, okay, deep thoughts. I totally agreed. I was like, maybe I won't read into this as much. And that is a little bit about low-level viremia. So I'd like to end with ART and weight gain and mention that this is not everything about ART and weight gain, but just some of the information. So again, it's not exhaustive, but at least will sort of help you recognize the relationship between ART and weight gain. And one of the cases is that really I've seen this in, and I've seen in several people, is a 58-year-old man with well-controlled HIV who was previously on TDF, FTC, and dolutegravir and was switched to Biktarvy just to as prevention to minimize long-term potential toxicity from TDF. And 6 months later, quite quickly, he gained 15 pounds. He actually lives a little off the grid and experiences food insecurity, is as active as possible, and has not changed how much or how often he eats. And so something happened with this change. So which one of the following combinations has been associated with the most weight gain? Is it dolutegravir in combination with TAF-FTC or Descovy, dolutegravir in combination with TDF-FTC or Truvada, elvitegravir in combination with TAF-FTC, well, also with cobicistat, or Cobi-elvitegravir in combination with Truvada? I think we can close the poll. Perfect. So 60% about stated dolutegravir in combination with TAF-FTC has been associated with the most weight gain, and that is correct. And I hope to show you that and why that is now. And I think that when it comes to this, I think chronologically, I find it to be most interesting because really a lot of this conversation started in at CROI in 2019. Many of you have seen me talk about weight gain before, and I do think that this chronology of the data I find to be very interesting. So pre-CROI, we had some data, everything was associative. And we saw that in the ACTG 5257 cohort in 2017, that weight gain was seen more in raltegravir than a boosted PI in treatment-naive individuals. Again, these were all sort of most of these were retrospective. In the Skolta cohort, there was no, in 2017, there was no difference between insties and boosted darunavir or rilpivirine if failing PIs, and no difference in weight gain. In the Vanderbilt cohort, there was more weight gain with insties than with the boosted PI or Atripla. And then the NEAT 022 analysis, which I am a big fan of, they found that in high cardiovascular disease risk, switching from boosted PI to dolutegravir not only was good for cardiovascular risk, but was associated with small but statistically significant weight gain. And this was actually an RCT and a sub-analysis of that. And so this data, I think, of the pre-CROI 2019 data, I thought was the most significant, or at least weighty. That's a terrible pun. However, if you see here that they looked at immediate versus delayed switch to dolutegravir, and in the red, it was an immediate switch to dolutegravir. So this red line upslope shows there was weight gain in the first about year, followed by a plateau. In the delayed dolutegravir group, there was still some weight gain. People are just gaining weight, but then that slope really increases once they're placed on dolutegravir. And we just don't have the data here to see that it likely plateaus. And then, as I mentioned, at CROI in 2019, an association between insties and weight gain was reported in a session with 4 abstracts. Everything was associative, and they said perhaps this is felt more to be more so the case with dolutegravir. This was big and prompted many of us to start talking to our patients about it. And I was bringing it up right after CROI, saying, you know, this is an association, but we're seeing it. And I think people really care about weight gain and want to know if they're going to experience that. And a lot of people want to avoid that. This is not something I'm going to go through, but just a resource for you if you wanted to sort of like know what the abstracts were, what those studies were, and just notice that they were all retrospective, which is why I was sort of talking to patients about how this is an association. And I thought this was a talk from that Croy as well, talking, and this is a image about how weight gain is multifactorial. And I think at that point I was like, okay, this is an association, and I really believe in this, right? That weight gain has effects from antiretrovirals and HIV, from diet, activity, the environment, the host, habits, and mental health. So although I was talking about this with patients, again, I was still like, oh, there's a lot of stuff going on. I wonder, is it really the INSTI? These are some great medications. Like, what's going on here? Then in 2019, later, we got results from the Advance study, which was from a randomized controlled trial in sub-Saharan Africa, so not just America, where I thought certainly people were definitely gaining weight. And this was actually a study not looking at weight, but actually comparing TDF FTC efavirenz versus TDF FTC dolutegravir and TAF FTC dolutegravir. And in this, they actually found that, you know, again, not what their primary outcome was. They were looking at sort of efficacy of these medications, that the combination of TAF FTC plus dolutegravir led to the most weight gain. I think this was very powerful information for me in my sort of narrative of this, because this is data from an RCT, and it comes from a different continent. And here you'll see that in the green, which is the standard group, which was people on Atripla versus people on Truvada and dolutegravir in the blue, versus people on Descovy and dolutegravir in the orange. And this was in female patients where it was seen, which was much more sort of higher rates of weight gain. This is a lot of weight, 6.4 kilograms over a year. So I thought this was pretty profound. Then at IAS in 2020, we got information from the OPERA cohort that demonstrated weight gain in people with HIV switching from a TDF to a TAF containing regimen, most pronounced in the first 9 months after switch. So I think, and with Advance, we're like, oh, maybe is there a difference between the Truvada and the Descovy? And then we continue to see a little bit more of that here, sort of showing that it's not just the dolutegravir that's causing the weight gain. And I thought that it would be helpful to show that the weight gain in the OPERA cohort, as I mentioned, occurred in the first 9 months, but here is just a visual of it where you can see there is this uptick and then a plateau. And then at ID Week in 2020, there was a cohort study that found that switching from TDF to TAF was associated with more weight gain than switching from abacavir to TAF. So I think at this point, at least again in the narrative, we started sort of hearing a little bit more, oh, maybe it's not just TAF, but maybe it's the absence of TDF. Is the TDF doing something, sort of making people stay smaller or sort of have less weight gain? Is there some mitochondrial toxicity with TDF? And so I think that was something that came from ID Week 2020. And then last, interestingly, from IAS 2021, there was Tango, which was looking at dolutegravir in 3TC, 144-week review of that study and of their metabolic outcomes, showed that there was weight gain with both regimens. So people who were on TAF with dolutegravir or like on their 3-drug regimen versus dolutegravir in 3TC alone. So it's people are, you know, there's some weight gain with this dolutegravir arm as well, even without the TAF present. And then I thought that it would be helpful to show this information from a pooled analysis of the 8 ART START trial, or at least from not the, but from 8 ART START trials, where here you'll see that weight gain was shown most significantly. Weight gain, the weeks is on the x-axis, y-axis is kilograms, that most with the integrase inhibitors, and you'll notice here that the confidence intervals do not overlap. Looking at the integrase inhibitors themselves, bictegravir, dolutegravir versus elvitegravir, there is more weight gain seen with bic and dolutegravir pretty similarly as compared to elvitegravir. And then looking at the NRTIs, that the most weight gain is seen with TAF, then with abacavir, and less so here with TDF, and then not with AZT or zidovudine. Again, what is TDF and zidovudine doing to the body? What's the mitochondrial toxicity here, sort of preventing people from gaining weight, as opposed to abacavir and TAF? And then I'd like Brian Wood, who many of you know, has a really nice article in OFID from 2021 talking about weight gain, but also with this nice image has proposed mechanisms for TAF and INSTI related weight gain. I hope to do this some justice, but will mostly read that sort of taking TDF or other non-TAF NRTIs with an NNRTI or boosted PI can suppress the appetite or weight gain with potential mitochondrial toxicity, and that weight gain, we also have some contribution here, it can be suppressed more with certain pharmacogenetic profiles. Then ART regimen change to TAF and or an INSTI occurs, or you start an TAF plus an INSTI, which then might remove suppressive effects if previously taking ART, lead from the INSTIs to interfere with adipocyte differentiation, thermogenesis, and other estrogen-mediated metabolic pathways, potentially have where the INSTI also directly affects adipocytes and other hormones that regulate glucose and lipid metabolism, where the INSTI may suppress melanocortin stimulate systems, which increase appetite. And then the INSTI can also chelate magnesium, which reduces insulin sensitivity. There's a lot of potential mechanisms here. Recognizing I did not do this graph justice, but I just wanted to highlight that the mechanisms are, I think, we're still trying to figure this out. And this is some proposed potential ones as to why the TAF and INSTI related weight gain may be occurring. And then what about PrEP and weight gain, right? Is it the HIV or is it the medication itself? In the Discover study, which was again what showed us that Descovy was non-inferior to Truvada for PrEP use, the TAF FTC was associated with weight gain as compared to TDF FTC, and there was a 1.2 kilogram difference in body weight change between the groups. So more weight gain in TAF FTC even in someone without HIV. That the Discover, and I'll talk about this graph in a second, that in the Discover open label extension, the median change in body weight at 48 weeks was 0 kilograms, and at 96 weeks was plus 0.5. So people in Truvada gained that, whereas in the Descovy arm was plus 1.0 and plus 1.7 kilograms at 48 and 96 weeks. So people are gaining weight more so in the TAF FTC arm. And then here is this image of a case report from OFID, which showed a 61-year-old cisgender man who had previously had obesity, who intentionally lost weight, was on Truvada for 21 months, and then switched to TAF FTC to reduce long-term toxicity. And you'll see here what his weight was. Green is switching from Truvada to Descovy. Weight went up, and then he switched from Truvada back to Descovy. Here it indicates that his weight did come down. That is not something that I have seen. This is just one case in PrEP. I have not seen this weight gain personally in my patients on, or at least patients on PrEP that I'm taking care of. But with patients with HIV, with the weight gain, I have not seen that weight gain come off yet, even when we have switched off of a TAF or INSTI related regimen. And so what should we do? Talk about lifestyle modifications, encourage patient to meet with nutrition, refer a patient to the Do It study. That's the ACTG 5391, and that's an RCT looking for those who were on an INSTI and TAF with greater than 10% weight gain in the 1 to 3 years after starting the regimen, switching either to Truvada doravirine, Descovy doravirine, or to continue their current therapy, which will then give us information on if switching off of these regimens can lead to weight loss, or what other sort of parameters they may be looking at. And the DHHS states that ARV-associated weight gain should be a factor to consider when initiating or changing ART, particularly in Black women, because women in general and Black women in particular experience greater weight gain with ART over time than men. And then to date, it remains unclear whether switching to a non-INSTI-based regimen results in the reversal of weight gain. And hopefully we'll find that information out. I think the other big thing to take away is when your patient comes in, get weights on them. I know most of us do that, but not all of us always sort of look at that or sort of really process that. And so I think that is a vital sign worth thinking about more, especially in this era. So some key points are that INSTIs are associated with weight gain, especially dolutegravir and bictegravir. That TAF is associated with weight gain. The combination of TAF and dolutegravir may lead to the most weight gain, and more information is needed on both the mechanisms and recommendations on how to manage weight gain. And so with that, I am done. Happy to answer any questions that might remain.
Thank you so much, Jehan, for that really awesome talk. There were a few questions. I think you addressed most of them during your talk. I see Adrian posted in the chat about a virologic failure paper that just recently came out. Yeah.
I mean, like, I think they exist, like so many papers say it happens and so many papers say it doesn't. I think I just haven't seen it bear out in that way. It doesn't mean that it doesn't occur, but I think I feel less worried about that. But I don't, I mean, I think any advice for counseling a patient with low-level viremia who is very anxious about being detectable? That's such a good question, Adrian. I think oftentimes when I've been in these scenarios, I've been more nervous than the patient. And so I think going through the data with them, it's hard though when data like this comes out, because which data do you believe in? Again, most of these data, the data is retrospective. So like, there's not going to be an RCT about this that I'm aware of. So I think talking about your personal experience with patients, telling them this, and I think, actually this patient of mine that came in first came to me and was like, can I add fostemsavir? I still have a detectable viral load. And what I did is I actually pulled up the national HIV curriculum. We read from it together, that they have a little blurb on the low-level viremia. And he was like, oh, okay, I don't need to add fostemsavir. And then we talked about it and he felt more comfortable with it. So I think showing him some of the data, that means, yes, you might have to cherry pick the data. But I think there's really not a whole lot we can do about it. And so I think I would sort of err on the reassurance, but yeah, thank you for bringing this up. There's a bunch of new stuff that showed that it is with increased risk. There's this other bit, I don't know. It's hard to know exactly how to interpret it all.
Thank you, Jehan. I have one question. In your practice, what are you doing for your patients with osteopenia and not osteoporosis in terms of follow-up screening? Because you mentioned that there's some recommendations to repeat screening, but there seem to be variable.
Yeah, they are variable. Again, the guidelines are a little more variable and say that you can sort of repeat in a couple of years. The talk I went to with Dr. Brown and another osteoporosis talk I went to from endocrinologist recommended a Dexa Scan yearly if someone has osteopenia. And so that is what I'm doing. Oftentimes, as I'm sure all of you know, there's so many other medical problems going on that the osteoporosis screening kind of gets pushed back. So I can't say that it happens exactly at the 1 year mark, but my plan is that if someone has osteopenia, I'm trying to maximize their bone health, and then I would get a Dexa scan in a year.
Thank you so much. I think we're at time. Thank you again, Jehan. That was really high yield and so helpful. And thanks everyone for joining.